Good evening and welcome to Health Smart. My name is Joanne Campbell and I'll be your host tonight. Health Smart is a series of programs brought to you by Hudson Valley Hospital Center. Every month we bring you a new topic and a new guest. And tonight I'm very excited to introduce Dr. Kelemen, who is coming to us to help us open a fantastic breast center here at the hospital. Good evening, welcome.
Hello, it's really great to be here. Thank you.
Okay. Why don't you tell us a little something about you and what brought you up here to Hudson Valley?
Well, first of all, I'll tell you about me. I'm originally from New York. I'd grown up in the end of Long Island, the North Fork. Went to a medical school in Stony Brook, and then I did a little 17-year tour of the country. Spent about 10 years in Chicago, and had the opportunity to go to Los Angeles and work with some of the best and brightest in breast cancer and melanoma. Then I spent 5 years at St. Louis University on faculty, was head of their breast center, and eventually became head of the cancer center. And then decided I really needed to get back to New York. Nothing pulls you more than home, and so I ended up coming back here to the New York area with a good friend of mine who had trained at University of Chicago as well, Dr. Andrew Ashikari, whose father had originally started the breast center so many years ago. Roy Ashikari, who's really the heart and soul of this breast center, started this after coming up to Westchester from Memorial Sloan Kettering. And he was on faculty at New York Medical College and then started his own breast center by himself. And then his son joined, and then I joined a few years later.
Very good. That wraps up a couple of key terms here. The new center will be called the Ashikari Center.
Ashikari Breast Center for Roy Ashikari, absolutely.
And what's the vision?
The vision is really to bring quality breast care, and it's not just cancer care, but breast care to the northern Hudson Valley region. We've been down in the southern Westchester area, and we have a lot of patients that are up in northern Westchester and the other counties north of here. And so we wanted to get closer to our patients and to expand and create a really comprehensive breast center.
Center of Excellence. That's the Hudson Valley way.
And actually, we have we were one of the first in the county and in the New York area to get accredited by the American College of Surgeons for a breast center. And so that was very nice as well.
Yeah, it's, all your work, and now you can finally, dedicate yourself to breast care up here, and so we are so appreciative. Now, let's talk a little bit about breast health and breast disease, if you don't mind.
Absolutely. So I think one of the most important things women have to know about breast health is what's their risk of developing breast cancer, because that's the scary thing, the big C, right? And so what we ask our patients to know is what their risk is. That's very important. In fact, if you look at studies of doctors throughout this country, they don't do a really good job at telling their patients what their breast cancer risk is. And so that's one of the things we do in the center, is make sure the patients understand their risk and treat them accordingly. So breast cancer risk is, well, what's the main factor? Being a woman it helps. Although not completely, we certainly do have men with breast cancer. Older age increases your risk of developing breast cancer.
Older, is there a cutoff?
As a spectrum, generally. But I guess if you were to say cutoff would be 50 postmenopausal. And then having a family history of breast cancer is very indicative of an increased risk. So one of the things we do is to develop a program where we identify with the family history if they have a risk of having a mutation. So there's this entity called breast ovarian cancer syndrome, which breast cancer and ovarian cancer is linked. And we make sure that if our patients are in that category where they might have that mutation, we identify them and get them tested, because it's a huge risk if they have it.
That's the genetic factor.
That's a genetic factor. And so it's not perfect, but we can test, get a lot of mutations that way.
More information helps you identify the real risk.
And then what we can do is develop strategies for decreasing that risk, either through surveillance, which is very important, and you can add on, we all know about mammogram and ultrasound, but we'd add on breast MRI. MRI, of course. Frequent visits, nothing better than a clinical exam and a face-to-face meeting. And there's also medications you can give to decrease that risk.
So suppressing the gene's activity along that way, or more about breast tissue?
More hormonal. It's
Okay.
it's anti-estrogen medications.
Okay.
Tamoxifen, many women know, because that's given
Right.
for breast cancer.
Right.
It also can be given for high-risk patients.
Oh, I didn't realize that.
Yes,
Okay.
exactly. There's another drug that's similar to tamoxifen called Evista, which is actually developed originally to increase bone density for osteoporosis. Very important issue. And the good news is it also decreases the risk of breast cancer. So it's kind of two birds, one stone thing. Unfortunately, if you look at national studies, less than 10% of women who qualify for this risk reduction actually do it.
Less than 10%?
Less than 10%. Maybe one, because of they don't know their risks, and so they haven't been identified.
Right.
And also, you know, medications have side effects, and nobody wants to take something that's going to give them a side effect.
Now, your OB/GYN, GYN certainly postmenopausal, what, do women go there to evaluate your risk, or is a breast center really kind of this new way of being in our continuum where women would come to get their risks evaluated? How does that work?
Well, obviously, we recommend you come to the breast center, but you know that's not right for everyone in terms of access. I mean, if you're in this area, you've got us, and that's great. And we'd love to see you. But if you're in an area where there isn't a breast center, it's very vital that primary care physicians, OB/GYNs, identify this risk. And so what I developed recently through a contest with the American Medical Association was an app that doctors can use through either an iPad or an iPhone. And what they can do is they can look at their risk through that device. They can
calculate a risk?
They can calculate the risk of either for their patients developing breast cancer or developing a mutation, see if they qualify for extra surveillance, MRI, see if they qualify for risk-reducing medication or genetic testing. So we're actually, I think it's at the end of this month, we're going to find out who wins the contest. But if I don't win the contest, it doesn't matter because we're still going to produce the
absolutely, because that will, again, change that continuum towards the health side of healthcare, back to that wellness and prevention side, where we can educate physicians on here's how simple it is when the woman's in your office or wherever women access care, that they're able to do this. Actually, could women do it themselves?
Actually, you could, and there are sites out there, but I really developed the app to make it a one-stop shopping. So
great.
It's pretty exciting. Actually, so the most important thing is that the surveillance works. This screening works. If you look at the mortality or death rate from breast cancer, it's decreasing. And so the big question is it decreasing because of chemotherapy or because of screening? No one really knows. It's an area of argument. But if you look at states that have increased their funding for screening, 10 to 15 years later, their cancer mortality drops. And if those states reduce that funding for tough fiscal times, they reduce that funding for screening, 10, 15 years later, their mortality increases. So there is a very strong apparent causal relationship between screening and mortality.
Great. That's good news for everybody,
right? So, well, it's good news if women get their screening. The problem is the fear factor, right? Is so people are stressed about life anyway, and then to have another stress, which is to go get your mammogram.
I don't want to think about it. I don't want to think about it.
Absolutely. So what we do is try to decrease that stress. So we have, and our first way we do that is we have a great front staff, the secretaries and the physician assistants and everyone that works in the hospital. Right when you meet them, it's a friendly environment because we've all been to doctors where you get that snarky and the work. It's very difficult. So we try to make that as appealing and calming as possible. And then the other thing is we try to do things as minimally invasive as possible, not rushing to surgery, but doing, if we have to do a biopsy, doing it minimally invasive, and so that works as well. Something we're very aggressive about is doing breast conservation. So if a woman gets breast cancer, she has two options. She can get a mastectomy to remove the entire breast, or to keep the breast, just take what's called a lumpectomy, take the cancer out with the rim of normal tissue. And that needs to be combined with radiation. The problem is the radiation is about 6.5 weeks. So you have to show up once a day and get your radiation for 6.5 weeks. That's very difficult for many people, right? So we've been very aggressive at figuring out ways to decrease that time. And for the last decade, we've been using a machine that that administers the radiation 1 dose in surgery. So the woman goes to sleep, she gets her surgery, she gets her radiation, and she's done. And so that's a great thing.
So game on. You're already rehabilitating after your surgery.
And you don't have to, one less thing to worry about in your life in terms of, it's already done.
And then is there healing time and then you start your 6 weeks?
No, this is one dose of radiation, you're done. You don't have to do the 6 weeks. It's replacing. Now, it's not quite ready for prime time in all patients, but we were part of a multi-institutional international trial looking at this. And after a very short period of 4 years, it showed that just doing the 1 dose intraoperative radiation, intraoperative meaning during surgery once, was equivalent to doing the 6.5 weeks afterwards.
Awesome.
Awesome, right. So that's very exciting, and that's a program we're developing.
And Hudson Valley Hospital's Cancer Center, we might add, our new Cancer Center,
absolutely.
which you're coming in on the red carpet, and we welcome you, but we're going to have our own radiation tomotherapy machine there, but you're talking about something else.
And we're going to have this also, this intraoperative
in the OR.
radiation.
This would be some sort of
it can be done in the operating room or even afterwards, depending on the circumstances.
Okay, so before discharge, this is kind of the new way of thinking.
Right.
And that's really listening from the heart, because you started this by saying, you want women to come into a nice environment where it's accepted that their lives are busy, they're frantic, and now fear and disease isn't really going to help. So how can you...
Or shut-ins, people who have agoraphobia, can't get out, or don't have access to radiation therapy.
Older folks coming and going. If we're saying breast cancer increases on the way up, some of our elderly don't have transportation so well. So that's really great, something new.
Yeah. And then even for mastectomies, we're doing something interesting, if I can...
Okay, keep going. Keep going. That's what it's about.
So it was just kind of considered that when you had a mastectomy, the surgeon would remove the nipple. And when you look back at the research, there's no real reason for that. There's no huge recurrence rate in nipples that in women who get breast conservation, for instance. They don't have a lot of nipple recurrences. The nipple has breast tissue, but it's not particularly favored to have a recurrent area. So what we're doing now is we're doing this mastectomies where we keep the nipple in a majority of patients. It's not good for everybody, but a majority of patients we can attempt to keep the nipple and then do an immediate plastic surgery reconstruction at that time. So basically, they go in to have their breast removed, they wake up and they still have breasts.
Okay.
Which is, if you can just think about, again, the stress of breast cancer, it really helps that they know they're going to wake up. They're going to be sore they had surgery, but at least they're whole.
Right.
And so we're doing that for breast cancer patients and also now for the patients who are high risk, have this mutation. So if you have the mutation, your risk can be 80% chance you develop breast cancer during your life. So a lot of these women are like, I want these breasts removed.
So take the breast tissue out.
So you take the breast tissue out, we do an immediate reconstruction, which was pioneered by one of our plastic surgeons, Dr. Andy Salzberg, who's going to be here as well at Hudson Valley Hospital Center. And he pioneered this procedure of putting the one-step implant reconstruction so the women will wake up whole. And that's very exciting and adds to that whole comfort thing. I mean, if you're going to, it's a bad situation, but if we can calm things down as much as possible.
Well, put a beginning and an end on it, you know, and then I have to go for radiation, and then I'm going to have to go for reconstruction. This was really kind of where breast disease surgery was not too long ago.
Oh, it used to be terribly radical. I mean, that's the beauty of being a doctor who takes care of breast cancer, is that it started out very radical, very huge surgeries,
get it all out.
Absolutely. And now we've gone from very bad mastectomies to smaller, not as much tissue. Now we're keeping the nipple. Now we're doing breast conservation where you don't even have to have a mastectomy in the majority of times. Now we're starting to do less radical radiation. 6.5 weeks. And then, in addition, or chemotherapy was basically acting like just kill everything, shotgun approach. And now we're focusing in on just the cancer cells. So the chemotherapy is just killing the cancer cells. And again, what that means for the patient is less side effects because you're not just killing everything in the body. It's not a poison you're taking. It's designer drugs and antibodies that really go after just the cancer, leaving most of the body intact.
But this is all the studies. I mean, there's been a lot of money, and unfortunately, it's warranted because there's been a lot of breast cancer. And so, to see the treatment become so more refined,
absolutely.
We should be lowering the fear level in our community and saying, this is something that,
It's curable in many circumstances. Absolutely.
Okay.
The other thing, though, is with the risk, learning about the risk, it can be a little bit a double-edged sword in the sense that if someone doesn't have any risk factors, they can think, well, I don't need to get screening. Unfortunately, 75% of women who get breast cancer don't have any risk factors. So we're all universally affected by this, if you will. All women are universally affected by this, and they need to do their screening even if they don't have a family history and everything's, they've never had a problem.
Tell me, those 75%, is there any studies about, we have an obesity epidemic, we have a diabetes epidemic. Is there anything in the literature that's starting to help identify women at risk that wouldn't seem to be at risk before?
We don't know what causes breast cancer ultimately. We do know that exposure to estrogen increases it. So especially your endogenous estrogen. So the earlier you have your period and later you have menopause, that increases your exposure. If you don't have that exposure of your own estrogen being broken up at an early age by pregnancy, that increases your risk. So if you have your first pregnancy at a later age, that incre's your risk.
So it's still the estrogen factor.
So estrogen is still very important. But if you are obese, you have more estrogen. You're creating more. Or taking exogenous estrogen, especially the combination estrogen, progesterone, and like Prempro is for the hormone replacement. HRT, right, which was kind of given just willy-nilly.
And did we see breast cancer? I thought I read something that we did see.
The incidence has decreased.
Has decreased, and it was kind of right when they pulled the button on that deal.
But that's going to level out at some point.
Okay. Tell us about your practice here, because we want to give the audience as much information. So on-site, office hours, surgery hours?
Right. So, in order to accommodate all our patients, we see patients every day and we operate every day. That means that if you call the office and you need an appointment, we'll get you in whenever we can. And we really work hard on getting our patients in as soon as they can. They need to come in. And the surgery we do every day, so that if they have a particular day, particular Fridays is a good day, because people then can heal over the week and get back to work on Monday if they're having a smaller surgery. So we try to accommodate our patients as really as best we can. We have a office now in the hospital.
In the hospital.
It's a temporary office while a brand new cancer center doctor's office building is being built, and it's beautiful, and it's going to be state of the art and wonderful.
It is.
Yep, absolutely. And once that's built and we're able to move in, we're going to move in there, and we're going to be right next to the Women's Imaging Center. And that's going to be very important because it needs to be a coordinated effort. And so our patients will be going in between, coming back and forth between our center and the imaging center. And we have a kind of a back access, which is discreet for the patients as well.
Okay, so this is a breast center for breast health.
Breast health and screening and exactly.
And so as far as procedures, surgical procedures, the new equipment would be the potential of using this one-dose radiation.
One-dose radiation in selected patients.
And also the reconstruction. Let's talk from that. I know that your colleagues from Down County are also joining you up here. Can you speak a little bit about that?
Right. We have a great plastic surgery team led by Dr. Salzberg, who's leader in the field of this reconstruction. using a one-step implant that's a silicone implant that goes in underneath the muscle, and they put a little patch to keep it in. It's called a sling, and it gives a very good cosmetic result. And it's really wonderful for patients, just universally pleased with it after they're, some few months after they healed up and feel better, they really, they're back to...
They're back to good health, back to better.
Yeah, back to better. Maybe back to better, but, they don't lose anything necessarily. I mean, they're very active. We've got women who are triathletes who've had this surgery and are still very able to keep as active as they were.
Now, with the as a nurse, with minimizing surgery and minimizing radiation, and as we said, refining this, what's the incidence of lymphedema? Is that still around?
Lymphedema, unfortunately, is. The good news is we're doing less removal of the lymph nodes. You remove the lymph nodes in breast cancer in the armpit, and that increases the risk of getting lymphedema, which is really defined as symptomatic swelling in the arm, and it can be quite disabling. The good news is we were also part of the study through my mentor, Dr. Giuliano in California, who I trained with, where we looked at checking the lymph nodes, maybe 1 or 2 lymph nodes, and if they had cancer in them, then we randomized patients to either getting removal of all the lymph nodes or not removing them, because we had the sense that you didn't have to remove them, because if you have cancer in your lymph node, unfortunately, you're going to need chemotherapy, but maybe that's all you need. You don't need the surgery. And again, after many years of this study, thousands of patients, it showed that you don't need to remove the lymph nodes. This completely changed everything.
Okay.
And so now, a woman who comes in and has just a little bit of cancer in the lymph node, we don't need to remove the rest of the lymph nodes, thus significantly decreasing the risk of lymphedema. I think lymphedema is going to be more of an uncommon or rare occurrence, as today it's,
Great, that's right.
Yeah,
well, that's why I wanted to mention it, because for some of the older women out there, they remember their mothers or their aunts with this horrible lymphedema. And I think, again, for the audience to understand how refined the science of medicine is becoming.
Absolutely, because that adds the fear factor. So a woman has a lump, maybe not even be anything, or it could be something. They ask people, they ask older women, and they say, "Oh, it's horrible. You have this, that." Well, it's a different game now. It's
you didn't even know
changed.
women had breast cancer.
Yeah, no,
because of the reconstruction and the new modalities. Okay, in closing, you have any? I think what I'm hearing you saying is it's about finding out, taking care of the women in our community and breast health in the community. And so we're still encouraging physicians, OBGYNs to, look into the history, talk about breast exam. Is that still in?
Yes and no, actually, because it turns out women aren't very good at doing breast exam. And so that's why we recommend every 6 months. If you have a breast exam every 6 months, you're going to be fine. And generally, we either do it every 6 months, particularly for our high-risk patients, or we'll see a woman every year during their mammogram, and then their gynecologist will do it in 6 months.
Okay, and we have great mammography equipment. I know our radiology department is nothing but the best.
Yeah, absolutely.
We have digital, and so perhaps our breast center, not perhaps, our breast center is here, and it's up and running.
It's here and up and running.
And do you have a telephone, a direct call to your office?
Oh, certainly, 914-734-3490.
Okay.
And we also have a website, which is in development, but it works right now.
Okay.
It's westchestersurgicaloncology.com, westchestersurgicaloncology.com, or you can go to the Hudson Valley
website.
Also has a site. One of the things we're trying to incorporate with the new technology in the social media is we've got a Facebook site as well, so you can just go to look up, search Ashikari Breast Center. I have a Twitter feed, which I talk about women's health issues, and just look up Dr. Kelemen, and you should find me there.
Kelemen.
No. Kelemen. All E's.
Okay.
And then with our website, what we're trying to do is incorporate all the services in the community. Not just medical services, but non-medical services. So physical therapists to help with lymphedema and issues like that. Integrated medical facilities, people that use
Okay.
alternative medications,
Sure,
acupuncturists.
acupuncture, yeah.
I mean, all those, osteoporosis,
Yeah,
smoking
specialists.
cessation, all that help women in our
Great.
community.
So Women's Breast Health is here.
Yes.
We're so happy to have you.
Well, thank you so
And
much. It's
thanks
good
for
to be
coming
here.
on
Absolutely.
tonight.
Nice talking with you.
Okay, that's our show for tonight. Please join us next month for another great guest and another topic. Be well.